The session is called SAMHSA Funded Engage, Educate, and Empower for Equity, E4, Center of Excellence for Behavioral Health Disparities in Aging. And Dr. Sims is our senior medical advisor for NASMHPD. He is fantastic and involved in multiple projects, including tobacco cessation as well as health equities. He's worked in Maryland as a psychiatrist. He has been involved in psychiatry in the justice system. Just a breadth of experience over, I won't say how many years, Dr. Sims, but really a lot of experience. But fantastic. You just look like you're 20. But anyway, I'm going to pass this over to Dr. Sims. Thank you.
And thank you, Megan, and thank you, NASMHPD. Megan took away half of what I was going to say, so I'll be even more brief than I intended on being to begin with. I do want to thank everyone for this opportunity to moderate this last session. And I just want to start off with an old statement that you may have heard before. It's called, "You've heard the rest. Now prepare for the best." So today we are presenting the topic, SAMHSA funded Engage, Educate, and Empower for Equity. And that's the E4 through the Center of Excellence for Behavioral Health Disparities in Aging. So we're thrilled and thankful to have as our speaker for this session a very powerful partner of NASMHPD, Dr. Erin Emery-Tiburcio. Dr. Tiburcio is an associate professor of geriatric and rehabilitation psychology and the co-director of the Center for Excellence in Aging at the Rush University Medical Center. Now, the E4 Center actively advances training and workforce capacity with a specific focus on the community-based implementation of evidence-based practices and programs for vulnerable older adults who experience the greatest behavioral and physical health disparities in our nation. There's so much to be said about her background and her accomplishments. However, due to our time constraints, you can look into our meeting website to gather more information. So respecting that timeline, it is both my honor and pleasure to present to you Dr. Erin Emery-Tiburcio, who will bring us this afternoon's session. And please, if you have questions, place them in the chat box and we will get to them later. So Dr. Tiburcio, I will turn it over to you.
Thank you so much, Dr. Sims, for that very warm welcome, and was so excited to swap places with you today as E4 welcomed Dr. Sims presenting last week on his very well-traveled experience in trauma-informed care. So thank you so much. So very excited to be here today to talk with you about E4 and some of the critical issues that we have been hearing in part from you and from folks around the country as we move through this very difficult time in our pandemic experience. So the mission of E4 is to engage, empower, and educate healthcare providers and community-based organizations for equity in behavioral health for older adults and their families. We focus specifically on substance use disorders, serious mental illness, depression, and suicide, and where all of those overlap to either initiate or exacerbate physical health issues. And for older adults, this is a significant issue. I'll talk a little bit more about that today. And particularly as those issues are overlaid on low socioeconomic status, ethnic and racial minority status. And so our goal at E4 is to be able to address all of these issues for older adults. And so in that work, it's important for folks to understand that older adults with mental health issues are more likely than older adults to experience all kinds of things that are related to their mental health issue, but they experience more functional impairment than younger adults, poor mobility as a relation to it, symptom burden, they're in the hospital longer, and health issues that put them at risk for loneliness. And this was even before COVID. So as we think about COVID being a piece of this, it makes it even worse. And so older adults are more intensely impacted by mental health issues. And even in the context of that impact, they're less likely to pursue or engage in mental health or substance use treatment. And Also, if they attempt suicide, which you may be aware that white males over the age of 85 are the most likely to actually complete suicide, older adults are much less likely to survive a suicide attempt. And whether that's because they tend to use more lethal means, like those white men that tend to use guns, or even if they're using pills, less likely to, as Dr. Johnson was just describing, the changes in pharmacokinetics, that they're less likely to survive that kind of suicide attempt as well. And so even when primary care or other clinics are able to screen older adults for services, which is rare, far less likely that older adults will be offered mental health service. And even if they're offered, they're less likely to get adequate services, particularly if they're Black or brown. So all of those layers of intersectionality that make older adults our most vulnerable population. And I say our most vulnerable population in the context of a recognition that I just learned this morning in one of our policy academies in the state of Illinois, that 30% of youth in one of the counties in Illinois have been in the emergency room for mental health issues. In the emergency room, 30% of kids. So even in the context of that situation during COVID, it's interesting to think about age as a risk factor here, because ageism is the only ism that every single one of us will experience in our lifetime. All of us. It's evident everywhere we go, from greeting cards about sagging body parts to anti-aging serums to the diversity training that I just went to, where the diversity training facilitator said, "Oh, I don't tell people how old I am." To any one of us who might have said something like, "Oh man, I got out of that chair this morning and I knew I was getting old." All of these things put aging in such a negative frame. And when that happens, it's not just we younger folks, and I say we younger, I'm 48 years old, I have no problem telling people that. I'm young. Given my genetics, I'm not even halfway through my life yet. And so not only are we starting from birth talking about how aging is bad, but when older adults internalize those messages of aging being a bad thing, it turns out that older adults who have negative perceptions of aging have greater disease burden, lower life satisfaction, greater loneliness, and all of that worse than racism, sexism, and homophobia combined. And those effects grow over time. So the older you get, the oldest of old are extremely marginalized, even in their own personal experience, no matter what the rest of us might say. And those folks with negative self-perceptions of aging also increased functional impairment, depression, anxiety, suicidal ideation, and death. It turns out that if we engage older adults and are able to shift those perceptions, that positive self-perceptions of aging is actually incredibly protective. I'm hoping that's the case for myself. My grandparents were incredibly active, physically active. My grandfather ran his last marathon in his 70s. He won the 50 and older ski races in his 80s. And so I have very positive ideas about aging. I'm hoping that serves me well. I'm hoping you may be able to shift in your perspectives, and it may serve you as well. So with all of this, if we have so much structural ageism, what can we do about it? What can any one of us do about it? It turns out there's a lot we can do, and it starts with how we speak. So we all know elders speak when we hear it, right? The woman in the wheelchair who were saying, "Oh, it's okay, honey. Let me get that for you. Oh, sweetie, come on over here." When I worked in rehabilitation, my office was right around the corner from physical therapy. And in that space, I heard a small voice around the corner. I heard a professional's voice saying, "Okay, honey, come on now. It's time to get up." And then a little voice in response saying, "Don't you talk to me like a dog." That experience of being spoken to in elder speak we tend to think about it as endearing. And people from the South tell me, oh, honey, that's just how we talk. But if you talk to clinic managers in the South, they will tell you that they get complaints. Our partner clinics in Southern Illinois, in Tennessee, tell us that there are complaints when people are spoken to in that way. And it turns out it's not at all endearing. It turns out that it doesn't improve comprehension like we think it improves comprehension with children. Turns out it doesn't. It actually threatens your self-concept. Can you imagine if you walked into a boardroom in any meeting that you go to and somebody says, oh, come on, Dr. Sims, I can help you with that. Step right up on here to the table. How demeaning, right? And why would any older adult feel any differently from that? And it turns out for folks who don't have the language because of dementia to be able to say, don't speak to me in that fashion, that it can increase aggression in people with dementia, and as such increases nurse stress, burnout, and turnover, such that when we're able to shift the language that the professionals use, that's all of us, that we can actually make a significant impact on our own burnout, right? And we can decrease costs of care. We can also significantly improve patient satisfaction. And I say that very broadly because it's not just what happens in any clinic that you may or may not be in, or any community-based organization that you may or may not be in, but even out in the community. And we see this in every step of COVID, right? The headlines across JAMA, structural ageism and the health of older adults. We see that Italy was not allowing people with COVID who were over the age of 65 to have a ventilator. Ageism is just so structurally problematic, and not just for older adults, but what is this teaching our culture about who has value? And who has value in our society? Well, my gosh, you know, if you ask a 20-year-old, old is 40. So the vast majority of people probably on this call, sorry, we're all out of luck, no value. And so what opportunities we have. And so that's just all of us who may be relatively healthy. What about folks with serious mental illness? It turns out that older adults with serious mental illness experience profound ageism. And it's interesting that the average life expectancy for people with SMI is only 53 years. So they don't live as long. Why is that? Well, because of obesity, smoking, diabetes, hypertension, metabolic syndrome, hyperlipidemia. And if you look down that list, what are the risk factors for COVID? Well, gosh, maps on pretty quickly there now, doesn't it? So if we think about people with SMI are having more difficulty engaging in physical health, to be in physical health services to be able to take care of themselves and manage those things, they're also much more likely to be vulnerable to COVID. So folks with serious mental illness, disproportionately high risk. And again, those medical risk factors are the same medical risk factors for COVID. And in particular, when those folks are in residential settings, congregate care settings, really high risk of COVID, right? How many people did we see dying in nursing homes, dying in group homes? And because of health behavior risks, the idea that the challenges that folks with SMI have, cognitive, behavioral, physical challenges, make it a lot more difficult to manage personal protective equipment. So getting someone who really believes that, who has, you know, all kinds of beliefs about the government having impact on their lives, having, you know, a radio channel into their head, and you're going to try and get those folks to consistently wear masks and keep themselves safe? Unlikely. And so these are challenges that our healthcare system is responsible for managing. Because if we don't, what's going to happen is that people will die. And it turns out, so there some really interesting research in JAMA Psychiatry recently about COVID positive adults, that folks with schizophrenia and mood disorders, much higher risk of dying from COVID. And the age has been a significant issue as well, and women with SMI. So as we look again at those levels of intersectionality and how that ends up impacting older adults, it is significant. And as we think about then that secondary impact, Well, so during COVID, so much psychiatric and medical care has been deferred. We're seeing older adults come into our geriatric clinic at this point who haven't been managing any of their chronic conditions. And when you add a mental illness on top of that, it's been astronomical, the backfilling that we need to be doing to manage health, and the impact of the social isolation, and the fact that most folks who drank before COVID drank a lot more during COVID, and those with mental illness even more so. And without those kinds of supports of people coming into the home, here in Illinois, we've just had another enormous outbreak downstate, and with the COVID numbers being higher than they've ever been, which means that there are a lot of in-home services that are not being provided right now. Again, we had just gotten back into the home in June, and now some are stepping back out. So that loss of support from people who are trusted, financial hardship, and then, folks who aren't getting out and going places because it's not safe to do so, are sedentary, increasing obesity and cardiovascular risk. So I'm presenting a relatively doom and gloom situation here, but really what we're seeing is an opportunity. It's an incredible opportunity for us to work with our health systems to meet the needs of these most vulnerable older adults. And this is where E4 comes in. We have fantastic resources to be able to provide education and partnership building and evidence-based programs and resources for your older adults and families who you serve. I'm going to walk briefly through the things that we are offering, and wanting to make sure to leave a few moments for questions if there are any. So if you have some, please do go ahead and put those in the chat and or think about what you'd like them to be. At E4, we are focused on developing knowledge, skills, and attitudes, including addressing ageism in the healthcare workforce. We have a whole library of online modules. We're in the process of developing a foundational mental health competency certificate. So we keep hearing again and again in our policy academies that the behavioral health workforce is not prepared to meet the needs of older adults. They don't have the knowledge or the skills. We, in early 2022, will be launching this free continuing education certificate. And the CE itself may not be free, but getting the certificate is free. And we'll be equipping any behavioral health provider who would like to learn more about that. We'll be offering mini fellowships to be able to practice skills in that content. And our learning community offers monthly webinars that offer free continuing education. Would love to have all of you come and participate with us. This is where Dr. Sims recently presented with us. And we also are very invested in expediting the implementation of evidence-based programs. So we have our own developed safe home naloxone training for direct care workers, phenomenal program where we come in and we train your direct care work staff to be able to understand how to implement naloxone and opioid safety. And then those direct care workers teach the older adult and family about how to utilize that. It's a wonderful train the trainer model. We'd love to come and offer it for you. We have active listening skills trainings that we'd love to come and offer for your direct care workforce. Doing some amazing regional policy academies. I saw Sherry Dawson here, who was participating in our Nebraska Policy Academy, and we've been working in Nebraska and Illinois this year and coming up with some phenomenally exciting opportunities for cross-sector participation in meeting the needs of older adults. So if you'd like to bring a policy academy to your state, please reach out to me. Would love to hear from you. We are also very invested in trying to close those gaps between the healthcare system and community-based organizations, the Aging Network. Most of those organizations don't even know who each other are. So an older adult gets discharged from the hospital and they end up falling through the cracks between home health, the area agency on aging, the senior center maybe that they used to go to. Nobody's communicating with each other. And we have fantastic opportunities to be able to build those partnerships. Most folks don't know how to do that. So we are building toolkits on how to identify where your gaps are, how to identify who would be ideal partners, and how to build those so that they are both financially helpful for both sides of that organization and also sustainable. being able to look at your environment of care and assuring that you are providing the kinds of things like arms on chairs, visual contrast in your signage, font that's readable. My eyes changed at 40, and I have been having arguments with marketing ever since then about the 8-point font that they put some of their materials in. Additionally, we don't directly target older adults with our marketing, but we are very invested in providing resources to you so that you can provide them to the older adults who you serve. We're in the process of putting together video series on older adults with lived experience of mental health and substance use disorders, putting together a toolkit for engaging older adults and retaining older adults, both from an interpersonal standpoint of getting older adults in the door and providing services that will keep them there, as well as financial stability in being able to how do you bill Medicare effectively? And for your dual eligibles, how do you make that work financially in a sustainable way? So we're really excited about being able to provide all of these services with some phenomenal partners, including NASMHPD, and very grateful for all of the fantastic input that we have from our organizational supporters as well. And just as a quick plug for our upcoming events, we're offering culturally responsive cognitive behavioral therapy with older adults from national leaders. Dolores Gallagher Thompson and Ann Steffen are phenomenal teachers. 5-part free continuing education for any of your providers. Fred Blow is going to be talking about cannabis use with older adults. And again, to Dr. Johnson's recent presentation, Dr. Sasha Rackman is going to be providing a phenomenal talk on high-risk medications and polypharmacy for those of us who don't prescribe. We need to understand what we see in our patients and understand how to be able to talk to those prescribing providers. So I am going to stop there and welcome any comments, questions, thoughts, ideas. And Dr. Sims, we'll turn over to you.
Well, thank you. And thank you so much for this incredibly timely presentation. We realize you didn't have a lot of time to work with here, but in that timeline, you've given such rich information. What I think is really imperative here is that when we're talking about parity, we're talking about access, and we're talking about what we talk with the states, many of the states have asked the very questions that you were addressing in this timeline. How is it that we can engage the older population? How do we get them involved? And it's just so incredibly timely for you to talk about the access and the level of talk. I did have one question because I absolutely fell in love with the ageism piece. I have 20 years on you, so that ageism portion just kind of hit me with another piece of reality here. But we have a kind of what I would look at as a zone maybe of differentiation. You have your older individuals who in the beginning we paid a tremendous amount of attention to at the beginning of COVID because of the Alpha variant, and they did not have a suitable treatment strategy. Now they have a treatment strategy. Has there been any evidence on that you've seen that we've kind of dropped off and gone back to the ageism piece as opposed to continuing our regular viewpoint of taking care and making sure that they're taken care of well?
It's a great question. And I think, you know, there was so much fantastic work done early on to try to educate nursing homes about assuring that in nursing homes in particular, as that's where so many folks were dying, and that there was a lot of really early work and focus there. And I think that as we have protected some of our older adults, attention has focused much further away. And I think at this point, as we've been hearing in our policy academies, people are just trying to keep their heads above water with, you know, workforce shortages and, you know, behavioral health workforce shortages, and the fact that we don't have enough for any age. And so quite frankly, the older adults end up just staying at home. And so the social isolation increases. And so, yes, I think the short answer to your question is yes, we have reverted right back to our previous ageism of focusing elsewhere. And these are our most vulnerable folks that I would hope that we would be able to meet some of those needs, particularly where they are in their social isolation.
Well, thank you. Thank you so much for that. It's looking at everything that you've said so far and the questions that have been raised when we do our quarterly calls with the various states. I think you've opened up a door of possibility here So I'm going to ask everyone, if you don't already see it, Dr. Tiburcio put in the chat box contact information. I would highly encourage you to make that connection, talk with them, because we're at a critical crunch here, if you would call it. We have an opportunity. There are resources available. And again, I just want to thank you so much for an excellent presentation.
Thank you so much for having us. We'll look forward to continuing that conversation.
Wonderful. So I will, at this point, with no questions I see here, I'll turn it back over to Dr. Hepburn if he's available.
Thank you, Brian. Much appreciated. Excellent presentation.